So the relationship we have between cardiac output and stroke volume is the following. The cardiac output will be equal to the stroke volume, amount of blood pumped per beat, divided by the duration of the flow. So, in other words, what we have is that Q would be the ratio between V to T, and that will be in liters per minute. So when the left ventricle completes pumping blood into the aorta, recall, and the aortic valve closes, the maximum pressure we'll call PSYS for the systolic component of the blood pumping. In other words, the systolic pressure. So that'll be the max pressure. Again, when the left ventricle completes pumping the blood into the aortic valve closes, the maximum pressure you would have at that point we'll call PSYS. Right? So the blood pressure then begins to fall as the blood flows through the artery. So in terms of from the perspective of the heart, right? So the rate of the flowing of the blood depends on the resistance of a blood vessel. So that's another important part of blood pressure, the resistance of a blood vessel. There are three ways of looking at what affects the ability to blood to flow through your blood vessels. The three are following: the viscosity, and thickness, the viscosity of the blood, the length of the vessels themselves, of course, and then finally, the radius of your blood vessels. So that affects how well your blood can flow through your arteries. The thickness of the blood itself, how far it's got to travel, and the size of the tube. In other words, for the radius of the vessel. It turns out, for the most part, the viscosity right here of your blood is fairly constant, except when drugs are taken. So a lot of times when athletes, unfortunately, or other people fail a blood test, the viscosity of their blood is a little bit thicker than it normally should be, perhaps, for example, or even thinner. It's just not the same. And so it's been changed based on what expected for a normal person. So, except when drugs, that's fairly constant. The length of your blood vessels, if you think about the average human, you would expect the length of the vessels to be fairly constant as well, unless we're very, very different types of beings. For the most part, the length of our vessels is about the same. So what really matters the most in terms of modeling the resistance of the blood in the blood vessel is this last one, is the radius of the vessels. Right? So this is the main factor that you could say affects the resistance. Or affects the resistance of blood flow. And of course, that's a very important issue when it comes to looking at heart disease and so forth, in terms of blockages and shrinkages and clots, and looking at how well the blood is flowing through the veins. So certainly blood pressure is a valuable tool for detecting narrowing of your blood vessels, and that's why it's very important to look at this issue of the relationship between the radius and the blood pressure. especially in the case of trying to use blood pressure to detect either hypertension or atherosclerosis, which is basically the hardening of the arteries. The buildup of plaque and cholesterols and so forth. So those are two reasons. There's a direct reason to be constantly looking at people's blood pressure. All right, so let's look at what data is available to observe in the human body, and then look at how we can build this model for measuring blood pressure. All right, so what do we know experimentally? Okay, so experimentally, so what we can say is via experimentation, we know the following. We know that the systemic blood flow and let's call that Q sub S. Again, thinking about Q representing our cardiac output. So the systemic, during the systemic phase of the blood pressure measurement, which again relates to the pushing of the blood up into the aorta so that it can go on into to the body. The systemic blood flow, Q sub X, turns out to is proportional. I'll write this that way. It's proportional to the difference. I'm going to say to diff. It's proportional to the difference between your arterial and venous pressures. The difference between the pressures in your vessels, whether they're in your arteries versus your veins. All right. So one way of representing that would be our PCA term, subtracting out another term, which we haven't really talked about yet. We'll call it the pressure that would be found in your veins, and that would be PVT. And the proportionality factor would be a certain value. So we would say that the blood flow is proportional to the difference between these two different kinds of pressures, according to a certain resistance. So given a certain resistance, which really, as we've already discovered, is really going to be determined by the size of the radius of your vessels, if they've been shrunk or plaque built up and so forth, that's going to determine this. So what you've got is the systemic blood flow as a function of time. Could be represented by 1 over R sub S. Again, R sub S is the resistance factor, the constant of proportionality, times this difference, PA of T minus PV of T. Okay? Typically, though, this is so much smaller. The pressure in the veins is so much smaller than the pressure of the arteries. All right? So this is typically quite low. So that compared to the other pressure, it's very insignificant. So typically, what people do is they will measure then your systemic blood flow as just the arterial pressure divided by this resistance value, RS. They will just totally map that to 0. Right? Again, this R sub S value, this would be your systemic resistance. Again, thinking of the systemic phase of blood pressure, this would be the resistance found. And the measurement would be most likely mercury, a millimeter mercuries by liters by minute. 3-phase there. Okay. Again, liters per minute, you could say, divided into millimeters per mercury. Right? So, with that's one important representation, is the effect of resistance on blood flow. There's another particular term that we need to talk about before we're building our final model, and that's called compliance. So compliance, written this way, compliance, in terms of a vessel, is how stretchable it is. So it's the stretchability. So now we're talking about elasticity. Is it becoming rigid or not? Most importantly, the stretching, what that's doing, it allows the vessels, or we'll just say vessel, use one, allows the vessel to change volume. To change volume in response to changes in pressure. So if the blood pressure goes up, is there an expansion of the vessel to take account for that? Right? So you could easily see that the higher the compliance, that implies it's easier for vessel to expand in response to increased pressure. All right, so what that means is if you looked at the two, resistance of the blood flowing through a vein, a vessel, and compliance, the stretchability, they are inversely related. If your compliance goes up, your resistance level goes down. The blood can flow better. If the compliance drops, then your resistance will go up. And the amount of blood you'll be able to flow through the veins, the artery is going to decrease. So by experimentation, again, building a mathematical model based on what we call ground truth, in other words, what's known and what's measurable, via expectation, turns out that VA of T, again, the stroke volume related to arteries, is equal to this compliance factor, we'll call CA, times that pressure. Okay. So, very important now that we know that the blood flow is a relationship between, it's a ratio between your pressure to this resistance value, and that the stroke volume will be this product form of compliance times that pressure. Right? So again, in summary, before we go to our model, this is what we have from experimentation. You can clearly see there will be an inverse relationship between the resistance and the compliance.